Okay, so
no, we got to announce why we have spaghetti behind us.
I mean, today is National Spaghetti Day, so we put the spaghetti in the background. My family's Italian, Lombardo, so been there, done that, learned how to eat spaghetti.
We had to have a conversation about the spoon and the fork that Kurt's covering, but yeah, ultimately it's clearly important for today.
So today is co-occurring.
I just jumped ahead.
Yes, you did. Okay, the sessions are recorded. Remember that. And remember there is free CME. That's super fun. Again, please chat us the names of anybody else that's in your room so that they get their credit. Please rename yourself. It looks like everybody has. Feel free to turn on your video like Miss Bester. We love to see people's faces. It makes it so much more fun for us. Remember, we will take cases. If there's interesting cases that you might have, please feel free to talk to us about that, and that'd be great. So upcoming echo sessions actually Tuesday on the 18th on this echo, overlap of addiction and chronic pain, which I will be doing. And then you can see there's quite a few other ones coming up. So if you look at our Wednesday echoes, which is tomorrow is one of my favorite talks I've ever gonna do in the poppy seed defense. And it's all about poppy seeds and what kind of opiates are in those and how it confuses everyone. And it's just a really interesting topic. We have next week, the week following, Dr. Cresta Jones, who's boarded as well in addiction and she's a perinatologist. That's also going to be a wonderful talk coming up. So lots of great talks.
Yeah, because these are the laws that have recently changed in Minnesota on the mandated reporting. So kind of important for anybody that has anything to do with addiction and or OB.
Yeah, and I believe in a few weeks, we're going to have the state of Minnesota come back and have a little talk about the report cards. So that will be interesting as well. Our COVID echo, this is the big week. On Thursday, we have Dr. Mike Osterholm on. That should be amazing.
And
most everything.
Depressing.
He's amazing and depressing at the same time. And he's been on with us for a couple of times. And amazingly, most of what he's talked about has come true. So join us for Thursday. And again, the podcast today, we let loose one on the nitazines, which are actually another mu agonist that's out there. We had an overdose death in Minnesota just a week or two ago, very much like a powerful fentanyl, if you can imagine.
It's the new fentanyl, because potentially why not have a new fentanyl?
And you can buy it online. So great stuff. Again, technical assistance, we're always welcome to take phone calls. We get calls all the time. If you have questions about particular patients or concerns or medications, please call. We're here to help.
All right, we don't need to run through the objectives.
No, and
I'll
today,
hit them all.
Oh, can I introduce you? And today we have Dr. Heather Bell giving our talk. She flew in all the way from Little Falls, Minnesota to give this talk. And so I'll turn it over to her now.
Considering I'm sitting in my dining room, flew really far. Okay, this is, I'm sure when our friends at Stratus and the MFP got my slide deck, they probably all panicked because the slide deck is quite long. You can see we've already done 11 slides, so don't panic. We put a lot in here that we ended up taking out, so we might end up circling back at some point, but co-occurring disorders are huge. How often do we see, people with mental health diagnoses and substance use disorders, and how do they go together? Why do they go together? And so we're going to kind of run through that. Always got to start with some epidemiology. So if you look at the epidemiology, you can see alcohol use disorder. And now these are old numbers. You can see from 2010, ninth leading global risk. I loved it because most of the statistics you'll see throughout talk about the US. I just think it's important to realize this is global. And then that second one, when you look at the age 15 to 64, how many people use illicit drugs? How many of them had substance use disorder? How many of them used IV drugs? And then how many of them actually live with HIV? Because this isn't just, the actual use or the actual mental health. This is full disease burden. NIH, these are more updated numbers. Sorry, the years are not on here. Some of the top ones are more updated, the bottom ones are not. The resources pages all of these are from that. So if you look at the co-occurring, you can see that if you're talking about people with substance use disorders, it's quite high who also have a mental health disorder. People whose primary thing is mental health, a lot have substance use disorders. Why this says 50%, this is supposed to say a substance use disorder. This is supposed to say substance misuse. I'm sorry. So That's a little bit of a typo. And people with serious impairments, so serious mental health illnesses, serious people who are on disability or unable, serious people with schizophrenia, et cetera, 1 in 4 also have a substance use disorder. The most common comorbidities, anxiety, depression, personality disorders, we're going to break these all down in PTSD. Overall, if you have a substance use disorder, regardless of which one came first, it has a horrible negative effect on overall mental health. And I loved this because this is, where we started, non-medical use of prescription pain meds. This is our bread and butter. 43% of people in treatment for just this is just pills. This isn't heroin or fentanyl, also have a mental health diagnosis. So things that also play into that, and things that kind of result in having a comorbid mental health substance use disorder, all these bottom things. This is just a graphic that says that people with mental illness is the blue line who also have substance use disorder. Substance use disorder also have mental health diagnosis is that bottom line. Okay, so the intersection. Common combinations. I am not going to go through this whole chart. This is in the slides for y'all later. This is actually right out of, is this the big one? Mm-hmm. The big addiction book that Kurt actually read the whole thing before our boards. It's just really cool when you look through it. We just don't really have a ton of time. Okay, so we're going to go through some of the common combinations. So the common comorbid diagnoses. So depression actually gets tied hand in hand with cocaine often. And so if you look at this, and you're going to see this triangle type graphic that I made because it was fun multiple times, because it kind of all plays in together. So substance-induced depression or drug-induced happiness. So you get happiness from using the drug like cocaine. You have the alcohol or the drug wears off, you use more to avoid all the negative emotions, and then we just continue that cycle. Panic primarily, but also anxiety often goes hand in hand with alcohol, also benzos. So the things that will kind of take the edge off. We hear that a lot. Like you just want to take that edge off. You're high strung, all of that, just to kind of calm down a little bit. I'm going to quickly open this chat so I can see it as we go. Oh. Link to register for your Wednesday shot sessions. I will type that quick, sorry. Okay, if you just email Katie, you can get the link for Wednesday. Sorry, everybody, I didn't see that sooner. Okay, so bipolar often goes with substance use disorder, and I didn't break it down as to which substance because it really doesn't matter. They kind of all go together. It depends if a person has a lot of mania, if they have a lot of depression, it kind of fluctuates. This diagnosis of bipolar is the highest risk of substance use disorder out of all of the mental health diagnoses. Overall, there's a higher prevalence of anxiety and depression, but when you have bipolar, the percentage chance of having a substance use disorder is significantly higher. PTSD, similar to anxiety, but it gets its own slide because it's obviously one of the things that, especially nowadays, is being studied a ton, not just with veterans, but with a lot of people have a lot of PTSD, but it's very similar to anxiety with the alcohol and the benzos. And so the big things is not only is it veterans, it's all the other abuse, and they're using the substances to get rid of all of these things. And a lot of PTSD symptoms are similar to anxiety, thus the alcohol and the benzodiazepines. Suicide and substance use disorder. Again, there's not a ton of studies on this. They do go hand in hand. Not going to go too much into this. I actually lost a friend and a colleague. His funeral was yesterday, a fellow physician, fellow med school grad, to suicide recently, and the person you never ever thought it was going to be. So these are really real things. Long story. I'm not going to get into it because Kurt will probably hit me soon. Okay. So personality disorders, the prototype, especially the ones that's the highest for substance use disorder, is your borderline. This was higher than I would have ever thought. 6% of people in the US would be technically classified as borderline. I'll be 100% frank with you. I hate this diagnosis. I think people who are diagnosed with borderline personality disorder have severe persistent PTSD. They have a ton of trauma, and this is how they have dealt with their trauma. They kind of go back and forth with these mood swings. another talk. So a lot of scattered thoughts, very temperamental. They will use substances to kind of help control that.
That's your dog.
My dog just burped. Okay, schizophrenia, we're going to spend a couple slides on this because, again, it's very high chance with substance use disorder. Often schizophrenia, they just get obsessed with drugs and substances in any way, shape, or form. They don't want to take the prescribed meds. They take them, things get better, but they're preoccupied with things that are going to help them feel better. Often it's alcohol and often it's tobacco. Highest prevalence of smoking is in patients with the diagnosis of schizophrenia, 5 times higher than the general population. Mental health and tobacco overall, I'm just going to kind of fly through this slide, but as we've mentioned before, nicotine actually gives you energy when you're down and it kind of settles you down when you're anxious. So it kind of does a lot of things. So smoking is a huge risk factor for mental health, and mental health is a huge risk factor for smoking. So kind of when you're counseling patients, it's important to kind of keep that in the back of your mind. Now, this I found super fascinating when we talk about schizophrenia and tobacco. I mean, I remember even early med school, you just knew that people with schizophrenia smoked. Like it was just kind of that association that was just there. So this area in the brain, very close to the prefrontal cortex, the adulting part, is involved in all of these things. A lot of the things like your adulting and your executive decisions. Those areas connect with a lot of other areas, memory, emotion, reward. So things that very common for adults to be able to process. Patients with schizophrenia, the diagnosis actually have weaker connections just in general, regardless of whether they smoked or not. So it's one of those things that's early studied now because they're trying to find new treatments for schizophrenia. So these connections are already weaker. Even close relatives of those with schizophrenia are often also going to be weaker connections, which is sometimes why that can precipitate a diagnosis if they're using substances at a young age. We'll get to that. But it's also impacted those connections in people who have severe nicotine use disorder. So it's this weird connection that these two are actually really, really tied biochemically. Usually goes down to this nicotinic acetylcholine receptors. Hallmark. So if you were, and this is all very, very new research, if you were to take all patients with schizophrenia, they often all have lower levels of these receptors, which you need for cognition, memory, kind of a lot of those executive functions. The interesting part is the receptors they do have are very sensitive to nicotine. So patients with schizophrenia self-selectively smoke because it actually does help their schizophrenia. So it's not something you necessarily want to, depending on your patient, you just don't want them to smoke, but at the same time, you have to also realize that their mental health is probably going to get a lot worse. And so really there's a ton of research right now on trying to find nicotine-like substances that act like nicotine without all the nicotine complications. So super cool. Okay, so how and why? So why do they go together? Why is there comorbidity? So this is that whole causation versus correlation. You can actually have subclinical diagnoses of mental health. So things that like you might just be a little blah, you might have some blues, things that you would never get officially diagnosed with depression with, and that can still prompt drug use. People who can't necessarily recall when they started using substances can actually prompt mental health issues. So it's really hard to know that whole which came first. This is where we get into the meat and potatoes. So there's 3 common pathways when you're looking at why there's comorbidity. So we're going to run through all 3 of these. The common risk factors, there's a lot of them. So we're going to focus a lot of our attention on this because I think that's where it gets really important, especially clinically. So genetic vulnerabilities, we've talked about this a million times. Half of substance use disorder kind of goes down to genetics. There's multiple genes that are involved that the environment can impact, and we'll kind of move into that with letter B. But people with different genetic makeups have different abilities to kind of process drugs, whether it's the body process the drugs faster or slower. It can impact how much pleasure you get from it, and then just how you respond for a drug. And I think my best explanation of how patients respond to drugs is when you have some patients who take an opioid and they just feel like crud and they get nauseous and they're gross. They just don't like it. And then you have other patients who say, oh my God, it was love at first sight. That's part of their genetic makeup. So that doesn't necessarily mean much, except genetically, they were more predisposed. Genes also impact how people respond to stress, risk-taking, different behaviors, and we'll get into that as we kind of go through these. But there's a lot of genes that also are similar between patients with substance use disorder and mental health. These are the most common 3 neurotransmitters, and drugs can impact it, and different mental health disorders also have dysregulation of these neurotransmitters. So the second thing, letter B, epigenetic influences. So this kind of piggybacks a lot on that environmental factors. This is very complex and super fascinating. So we have our genes, we have our DNA that, you can't really alter that, but we also have these little proteins that sit on our DNA, and the proteins can decide, is this part of the gene going to be more active, or is this part of the gene going to be more active? And depending on which one is more active can make you more susceptible, or make you not handle stress as well, not make you handle trauma as well, or can make you handle it all really well. And so that actually, it doesn't depend on the genetics, it depends on the environment and things that were protective mechanisms historically. So things that can impact how the genes are expressed, stress, trauma, drug exposure, and it can be heritable. So this is where historical trauma comes in. We talk about that. Susan Bolio was on here and talked about this, and why people with generations of trauma, how the stress response kind of perpetuates through, but it can be impacted by changing environment, by changing interventions. Those proteins, the epigenetic influences can change. Also, a lot of the stress impact with this depends a lot on the developmental stage and when you're in utero. This I found super fascinating. If you're in utero and your mom eats a ton of fatty foods when she's pregnant, it actually changes the epigenetic, histone proteins on the DNA with the reward circuitry. So babies or kids and people who were exposed to that high fat diet often don't find normal, pleasurable stimulus as pleasurable. So they are actually more likely to find exogenous sources of pleasure, i.e., something that would raise your dopamine artificially. Poor maternal care also can impact this and how people respond to stress. Okay, letter C, brain region involvement. Everybody knows my favorite part of the brain is the prefrontal cortex, the adulting. This is impacted by both substances as well as mental health. And then we get into that. All the neurotransmitters involved in all of that can be impacted by both, regardless of which one came first. So if one of them gets diminished because, your serotonin is low, that can actually impact, because of your mental health or depression, that can actually impact you seeking substances to try to raise your serotonin. Okay, so D, environmental influences. Chronic stress, this kind of, again, piggybacks back to the whole epigenetic histone thing, but this is more for individual persons, not genetically or generationally. So chronic stress, trauma, adverse childhood experiences, this just all increases our chance of mental health as well as substance use disorders, not saying one always comes first, but this is where it's really important to have those diagnoses early so we can do some early interventions and or prevention things. So this is if you have high-risk families, high-risk neighborhoods, high-risk patients, you really want to address that early. And then stress, of course, common risk factor, high stress can create mental health. If you're always stressed, you might be more anxious, you might be more depressed, depending on what that is. Therefore, you might go to substances to kind of artificially help that. But high stress may cause you to use substances to alleviate your stress. And then the substances change the brain, which then can give you a subsequent mental health diagnosis. So this is that whole fancy HPA axis. You can see the fancy diagram. And this is where stress is really a big risk factor for lapse and relapse. And this is why treatment, that therapeutic community really come in to help people learn different coping mechanisms to handle the stressors of, life. Stress just in general does alter everybody's favorite prefrontal cortex. So you're less able to control impulses. You're less able to have control over your actions, your thoughts, if you're under stress. And this is universal. This is for all of us. And so depending on your other risk factors, this is where substances might come in and or mental health diagnoses. Early life stress definitely can impact this too. So this is where we're talking kids, we're talking even in utero, we're talking those really impactful years, the 3 to 5 or birth to 5, can really create a lot of havoc in those pathway formations, which can then lead to troubles with kids being motivated, troubles learning, troubles with them adapting to different environments. So this is why if there's ever big life stressors in kids, it's really important to have those interventions early on to try to alter this alteration to minimize that progression and that risk later on. Dopamine, I'm just not going to go through this, but the best treatment for the high stress is your mindfulness-based practices. And then finally, trauma and adverse childhood experiences. This is often you have some trauma, you use substances to relieve that anxiety. You don't want to deal with the trauma. You don't want to deal with the consequences. Not that you're choosing to do that. It's just your brain is needing help because it's so heightened. If you look at service members, and this is obviously, again, old data, but 1 in 5 veterans with PTSD also have a substance use disorder, but most of them don't actually get treated. So the second path is mental health precedes the substance use disorder. And so it's saying that people with severe mental health diagnoses, this is that whole common thought. I think this is probably people's way that they typically think, is that you're using substances to self-medicate, to reduce your symptoms. But then as things are perpetuated, your symptoms get worse and then you use more and more and more. Common symptoms people feel that lead them to using substances, if they're doing that self-medication: loneliness, shame, distress, stress in general, blame, humiliation. So these aren't what people are feeling once they're already using. These are just things that people feel on their day-to-day, which then lead them to using substances to help alleviate these feelings. This is my favorite little diagram I've probably ever made. So this is kind of the visual of what this all looks like. As you get a mental health diagnosis, you get the changes in the brain similar to what we just talked about. Those changes make you more vulnerable. So it actually enhances rewarding effects of drugs or substances. It actually decreases your ability to notice the negative consequences. So that's kind of, if you take a patient with severe meth use disorder, opioid use disorder, they just haven't showered, they haven't, they don't care about dental care. They don't care, like they just don't even realize these are negative impacts. And then sometimes the substances alleviate the symptoms of their diagnosis, and they'll take away the side effects of the medications given to them for their diagnosis. So there's a lot of layers here, which is why this is an important talk, I guess. And so an example is this is proven on neuroimaging studies. People with ADHD actually have changes in these circuits, and they have greater cravings, patients with substance use disorder, if they also have comorbid ADHD, because of the changes in the brain circuits. Okay, so number 3, this is the third pathway that substance use can then cause subsequent mental health diagnosis. So using substances can trigger and bring on, often these are the kind of big 4. Schizophrenia can be triggered, can come out of where you were predisposed. Anxiety, mood disorder, impulse control disorders. Here's the visual of this. So you have drug use, you get changes in your brain structure, you can get some mental health symptoms. But some of these changes in your brain structure will actually bring about these underlying mental health predispositions. So not everybody who's predisposed to getting schizophrenia is going to get it, but substances can actually trigger schizophrenia to come to light. That's the classic one. So it's that whole, what came first, the chicken or the egg? Every time we do this, we got to find a new graphic or new picture. So what do you do about this? There are tons of gaps. Obviously, this is why we're talking about this. Patients who have mental health diagnoses, substance use diagnoses, over half receive no treatment for either one. About a third receive only mental health treatment. Only about 4% receive only substance use, and only 9% of people actually receive treatment for both of their comorbid diagnoses. And part of the problem is if you look in the bottom, only 18% of substance use disorder programs even have the capacity to deal with the mental health. They're focusing so strongly on the substances, they don't have the right setup to also deal with mental health. And then even more sadly, mental health programs, so people are in inpatient mental health programs, they don't have the capacity or the ability to also deal with the substances. It's interesting because if you're in an ER and you need to send somebody to mental health inpatient, you have to get that drug screen, and they don't ever want to take them if they're on any substances because they just can't handle it. So it's really hard to find treatment for both. Just barriers. These are common barriers. I'm not going to go through them, but this is why people don't get the mental health care they need, the barriers. They don't get substance use disorder treatment. They need the barriers. But there's also just, a structural, issue. Universal access to healthcare in general is bad. Mental health care, it's worse. There's not a lot of availability of evidence-based treatments. If we're talking about medications for opioid use disorder, that's why we're all here learning how to do this, but there's not a ton of treatments. A lot of healthcare providers just aren't clinically skilled in providing this addiction care. And then there's different resources, of course. And then when you throw in stigma and discrimination, it just makes it that much worse. We really don't like the whole siloing thing. So we're using grain bins now in our world, because at least there's this, semi-connection we're trying to bridge. It's kind of like the hope. I'm just kidding. Okay, so this is where kind of what we just said, but you have mental health treatment over here. You have substance use disorder treatment here. People don't like to cross. And then depending on your treatment facility, some don't want any medications. They think everything should be abstinence-based. And some mental health treatment facilities think that you should not have any meds. It should be abstinence-based if they happen to have a person with a substance use disorder also in their mental health program. So there's a lot of disconnect. A lot of places don't have the clinicians to prescribe, dispense, and monitor. We've seen that before, where people you can't get the meds because there's no one even to give them. That's getting a little better. And then the criminal justice system, and we could go on and on about that. So a couple studies, and I didn't spell organization wrong, which is why I put their actual graphic at the bottom. So you can see that I didn't spell it wrong. Did a study and said, if you just did simple SBIRT, so screening, brief intervention, referral to treatment in primary care, even for only a third of the patients with alcohol use, you could actually decrease the prevalence of the harmful use by 10 to 15%. Doesn't seem like a huge number, but overall, it really is, because alcohol is so common. And then you could decrease the chances of developing alcohol use disorder by 1 to 4%. And this is just with asking and recommending people to cut back and potentially referring to treatment. So this is just having that conversation. European did a study of 60% of people with alcohol use disorder were actually given, one of the proven medications to treat or help with alcohol use disorder. You can actually decrease the deaths related to alcohol use disorder by this much, which those are actually pretty significant numbers, I think, because 10% of women, 13% of men could not die in the next year related to their alcohol use, just for actually treating their alcohol use disorder. I just had to put a squirrel in here. Stigma is always a huge thing. Marginalization. People have self-stigma. They're afraid to seek their own care, both mental health and substances. Social isolation. Sometimes there's families who also feel isolated and don't want to seek help because they feel judged for a loved one having a use disorder. Healthcare providers, leaders, people who make the laws and the rules don't actually have a lot of great education about substance use disorders in general, screening for them or treatments for them. And just, we need to do more education. Okay, so good treatments. Non-medication treatments, you really want to leverage different things. I'm fine. He's checked the time
That's my job.
Every 3 minutes. Okay, so you want to find things that are going to leverage behavior, cognition, motivation. So things to kind of, again, I always say, like, you just need to learn new coping things, new ways to process things. The best treatments, non-medication treatments, cognitive behavioral therapy, motivational interviewing techniques, contingency management, especially for things like meth where there isn't a great medication. Actually, gender-specific treatment for women, I don't like to have to differentiate ever anything, but this really focuses on, trauma, sexual abuse, sex trafficking, which is more common in women. And there's, I've had a lot of patients who struggle when even going to drug court if there's men in the room as well, because it's triggering. So it is important to at least identify that. Support groups, mutual support groups. There's a ton of other, different types of these, AANA, and the list goes on and on. Alone, AA was historically very successful, the treatment of alcohol use disorder. Now all of these support groups are adjuncts. They're not standalone recommended treatments. Recovery coaching. So this is where your LADCs, your peer support, your people who are in recovery, it can help. And it's more that mentorship. It's that having a sponsor. There's still not a ton of data because there's just not a ton of recovery coaches, especially in greater anywhere. And then behavioral therapies, this is group, it's individual, and it's really patient specific. Some patients will do just great in a group setting. Some will not do great in a group setting. So it's, again, very patient specific. Groups are, more efficient use of the therapist's time. You do get this therapeutic community. People are all in it together. These people understand what they're going through and what we're going through, and you kind of all go together. But we have a limitation on therapists and people who are trained in this. All right, behavior, wrong slide. Okay, technology-based, this is kind of a new thing. And so they can have apps, they can have computers, sometimes it's support groups, but what this is really talking to is, like, you have an app that you can go into if you're stressed out or you're feeling a trigger, and you can text or email or reach out to some random person in some random cloud in the world, and get some support. And so obviously there's going to be limitations, internet, cellular power services. There's this big question on who's liable then. If you tell some random person in the world that you're feeling suicidal, what happens if something happens? So that's kind of one of the things, but this is definitely a new thing coming down the pipe. Medication treatment, always about safety. Big topics, detoxification. You want to prevent the withdrawal, life-threatening withdrawal. So this is really kind of like your alcohol, your benzos, things that can actually be, opioid withdrawal can be life-threatening, but we're really talking more the ones that are historically always life-threatening. You want to provide comfort with meds. You want to prevent and provide relapse and lapse prevention. So priorities, and when you really should use meds is in alcohol withdrawal, sedative withdrawal, like I just mentioned. Obviously, opioid overdose with naloxone, benzo overdose. If it's a straight benzo, flumezanil, very rarely do you have straight benzo. We do obviously have medications available for these use disorders. We're going to kind of quickly point them all out here. So full agonists, we know methadone, NRT, so nicotine replacement, your gums, your patches, they do help. They're medication things that have been proven to help cut back on whatever substance. Partial agonists, your buprenorphine products, your varenicline, Chantix, that's a partial agonist to help with that. Antagonists like your naltrexone, your Vivitrol, and then there's a burst of medications, disulfiram, so Antabuse. So people that drink alcohol, they take this, they get sick. So different medications. And then just a comment on things, if there's people who have this co-occurring, are there things you should be aware of? There are things you should not be aware of. I think the biggest one I always think of, which isn't actually not in here, is patients who you're questioning bipolar, you give an SSRI to, you can actually throw them into a manic state. And so that didn't really have much to do with substances, so it didn't make the cut. But if you're looking at ideal medications to treat co-occurring, most of them are done on anxiety disorders and most of them are done in alcohol use disorders. These have been around longer, at least acknowledged longer, but there's very few trials literally overall. SSRIs, a primary class studied for a lot of different obvious reasons, some modest benefit with alcohol outcomes. But if we're looking at specific studies, paroxetine, aka Paxil, this first study only had 15 people, did show significant improvement in the social anxiety and in some alcohol outcomes. They didn't really kind of go into what that meant. Next study, all the patients of these 42 all acknowledged they were drinking alcohol to mitigate their anxiety. That is why they were drinking. And so they had a significantly greater reduction in social anxiety on paroxetine, but no effects on their drinking outcomes. So even though their anxiety got better, they were still drinking the same amount, but definitely something to at least. So basically that just tells me is paroxetine can be a good anxiety med. Sertraline, this study had 94 people who are all diagnosed with alcohol use disorder and PTSD. There was really no improvement for either significantly, but when they looked at subgroups, I find this super fascinating. So people with more severe alcohol use disorder who also had PTSD that was later onset. So these are more your veterans, people who have, come back and their trauma happened later in life. They actually on sertraline had better alcohol outcomes. Didn't really comment much on their PTSD symptoms, but definitely had much better alcohol outcomes. People who had, some mild alcohol use disorder, moderate alcohol use disorder, but had early onset PTSD. So this would be your childhood trauma PTSD. Sertraline actually helped them with their PTSD symptoms. Didn't do a ton about the alcohol, but it helped with their PTSD. So it's just very interesting to me, like the differences, but also there are some positive outcomes here. You would just probably need another medication add-on. Buspirone, something I don't use a ton of. Maybe I will now, but 51 people with anxiety disorder and alcohol use disorder on buspirone had a greater reduction in anxiety. They did better in treatment. They stayed in treatment longer. They didn't have as much relapse, and they self-reported improvements. Another study, 67 people who had just gotten off of alcohol from detox, who had generalized anxiety, did have some improvement, although nothing was statistically significant. And then they looked at buspirone, and this was like one of the only studies when you're looking at opioid use disorder. And these were people who were already in a methadone maintenance program and had been stable in their methadone maintenance program. Really no significant improvement anywhere, except there was a subtle trend towards, pushing off lapse a little bit. But that could also be that they had been stable in their program too. Other medications, just to touch on, SNRIs, TCAs, MAOIs, and aside, my kids were just so confused by what these things all meant, these acronyms. And so when I tried to make them spell the actual words, they looked at me and ran away. So don't try to spell them. Anyway, so short-term benefit, just less than a month, they found imipramine, but really no benefit for cocaine or opioids. So nothing significant to even attempt here. And then benzodiazepines, they do work, of course, but there's a lot of abuse liability here, and especially the risk in people who have any personal family history of substance use disorder, which is probably most of us. People with more severe personal substance use disorder, they have multiple substance use disorders, which is very common, biggest predictor of a future substance use disorder is a past one. And then the more severe their mental health diagnoses. This is the last little chunk. I'm flying, sorry.
Doing well.
Adolescents. So this is the special population I'm going to spend a little bit more time on. I make one comment about women at the end, but that's about it. This is a time, like that picture, when drug use typically will start, and also a time when mental health diagnoses will commonly, start to show up and appear for lots of different things, like the genetics, the epigenetics, all the things we talked about. And there's a lot of challenges. These kids who have no frontal lobes, who can't executive decide anything, also have a lot of things going on. They always say, don't make many changes at once. Well, that doesn't happen when you're a teenager going into college. Changes in education, work, relationships. 60% of adolescents in drug treatment also have a co-occurring mental illness. So this is why this population is just so important to focus on. And I did not deep dive into all this data in making sure that it had been a month of free of use before the diagnoses. That's just, yeah. And a lot of it's going to come back to that brain development, So here we are back in my favorite part of the brain. Of course, this is the last area to develop, and this doesn't develop until the mid-20s. And just not having that executive control, you have more vulnerability to drugs. So earlier use is a strong risk factor for later substance use disorder. It's also a risk factor for other mental illnesses. And it's not necessarily causative. So this isn't just saying that every adolescent who uses any substance is going to have more mental health and is going to have more substance use disorder. That is what it's saying, but it's not just a direct causation. There is some correlation. There's other factors, the genetics, their psychosocial experiences, the environment, all the things that they're exposed to in their lives also play into both mental health as well as drug use. Any mental health diagnosis in childhood, so even if they're before that adolescent time and they have any type of diagnosis, ADHD, conduct disorder, we'll get to that in a second, increases the chance of substance use disorder. So really getting appropriate mental health diagnoses in young kids even does reduce the chance of having a subsequent substance use disorder. And this is another place where we could talk on and on about stigma and is this really, how kids actually have access, because we don't have enough mental health care. We really don't have enough adolescent and childhood mental health care. So if you get diagnosed with bipolar as an adolescent, it's much more severe than being diagnosed as an adult with bipolar. We already said bipolar is one of the ones that just has a higher risk of substance use disorder. If they're diagnosed as an adolescent, it's definitely a very, very high risk population. There is some research though here that shows kind of what I was trying to allude to is that it's not always the substances that cause the mental health, but a lot of youth adolescents have the depression, anxiety, which then they self-medicate just like anybody else. But marijuana is the one big one. So marijuana use in adolescents does bring out psychosis in adulthood in those who have that predisposition. And it doesn't have to be, somebody in your family who already is schizophrenic, somebody who already is bipolar. They might not have used to bring it out, but if there is a predisposition, the chance of having schizophrenia diagnosis or bipolar diagnoses is way up there. So this is why I'm not a proponent for legalizing marijuana more than anything. If you look at ED mental health presentations for adolescents, about 15% were also diagnosed with substance use. You can see percentage used with illicit of mental health. So far majority of mental health presentations to the ER had illicit drugs on board as well. And 60%, now this is back to just US data, mental health also has a concomitant substance use disorder. This is in general, that's not ER data. The top 2 bullet points are ER data, the bottom one is not. So the biggest risk factors, these are the diagnoses, the mental health diagnoses, ADHD, conduct disorders, and then just simple traits, not necessarily official diagnoses, but more aggressive children, more aggressive youth, adolescents, more impulsive, and then children that tend to be more depressed, anhedonic, high anxiety also can be implicated. So the question has always been, and I think we even debated this a couple of years ago until the research really started to show, the second bullet point there is actually treating ADHD does not increase. It actually decreases the risk of stimulant abuse later in life. Even though you're basically giving them amphetamine, it does not increase their chance of having any type of methamphetamine use disorder. Not treating ADHD definitely does increase the risk of drug problems, not just meth use disorder, but all drug problems, especially in those who also have the diagnosis of conduct disorder. And most kids, if you look at who gets diagnosed with conduct disorder, a lot of these kiddos are also in very high risk, high stress environments. So they're all that multifactorial. So this really has to be a lot of individual family counseling education. Quick thing on women, half of women with a mental health diagnosis also are battling high risk substances, high risk use, and or substance use disorder of some kind. I did it.
Wow.
Yeah, that was a lot.
That was a lot
And
of
I
information.
took out like 30 slides.
Well, that was amazing. There was a comment by Chris Madsen. She did note that looked like grain bins and not silos, and they were grain bins. We're just tired of silos, so we're no longer this year. We're going to be doing any silos.
No, I mean we've been working for how many years to get rid of silos?
So we're moving to grain bins. So
because there is some connection, and then there's that. Yeah. Anyway, I could keep going.
Any questions for Dr. Bell? Any thoughts or questions? It was a wonderful talk.
Hey, thanks. Who wants to know when I finished it?
Yeah.
No comment.
All right. Well,
Hold on.
are there questions?
I don't know. Oh, okay. I just want to comment that Kendra did put the slides in here for you all. Yeah, please reach out. That was a lot. The very end, and I didn't show them on my PowerPoint, there's 2 pages of references and resources. The one was like phenomenal, and we're gonna probably do another talk just out of a few of the pages in it because it was so good. And then to get your CME, please fill out the evaluation. Jane, did you have a case you wanted to discuss or mention or talk about?
I did not get a chance to put it together,
Okay.
but I will. I actually think it would be a good, it highlights absolutely every single one of the points that you brought up. And one of the other pieces, I think, that I don't know what there's an answer to, but it's the management of folks with mental health, substance use disorder, and in a congregate living situation. So,
I knew you were going to go there.
yes, which is very challenging because they wear the staff down. And it's extreme. And that was kind of, and I will put this case together because I think it would be a great one to discuss, because I have I'll put the med list out there and everybody will go, what? But it's been just almost next to impossible to reduce medications, to address some of these underlying pieces. And you would think it would be easier in a assisted living community, but the strain on the staff is just immense, and it's much easier to give in to the person's demands than it is to address the underlying issues.
I think often too, it's just like an addiction. I think that 5% of our patients take up about 50% of our time. And it's kind of that same thing as far as staff and those type of patients. Yeah.
Do you feel, Jane, I'm kind of glad you brought this up. So like assisted living, I'm assuming this person is at least over the age of 55.
Yes.
Okay. So do you feel that it's sometimes even harder because, they're isolated? They're isolated from like their family, their loved ones, if they have family and loved ones nearby. Does it get worse with that? Does it get worse with other people having more family visits? Does it get, or is it more, or is there another factor of they already got to whatever age they're at? And so that's a lot of years of, this is my coping. This is my tools. I only use a hammer. I don't use everything else.
Yeah, I don't know if it's as much of the isolation, because oftentimes, at least what I see, is you'll get a group of residents who have significant mental health diagnoses for a whole range, also have substance use diagnoses, and now they are their own community within the assisted living. And, assisted living, the liquor store delivers. That's not a problem. And you have no control, the staff have no control over this, but yet they are living in a community with other residents. There's a med cart, right there that they're hovered around, asking for every PRN available. So I don't know if it's as much of the isolation. They tend to find their own community of folks that also have the same issues and same coping mechanisms.
That's interesting, your description of all of that, because when you said the med cart hovering around, asking people, it reminds me of jail, except obviously no one's delivering alcohol to the jail. But I mean, it's almost worse than a jail setting, but without like necessarily the criminal background. But has there ever been that you know of, because I don't know of, but this might be something really cool to look into, they have their own community of they
like-minded people.
Like-minded, the coping, the substance, whatever. But that could almost be somehow flipped into a positive, like the therapeutic community. It's almost like you need to have that one person, whether it's a recovery specialist or someone come in and do AA or NA or run group meetings for in that kind of setting. But I wonder if that would be effective unless you found, again, a peer. So you'd almost have to have.
I don't think it's unlikely either that you're getting a lot of illicit substances in that place as well, right? I mean, these people have always been connected if they have substance use disorders, and you may very well have a lot of trading going on in that community as well. And so the number of medications they're on is probably just the tip of the iceberg, potentially.
It very well could be. Now, most of the folks, are there. There's also one of the things that might be in favor is many of the folks that have that combination and are in assisted living are often on a waiver program. So generally don't have the funds to go out and purchase, and usually aren't allowed to manage their own medications because they don't pass the kind of test of being able to do that safely. So there's probably less of the, hey, I'll trade you a Xanax for a, or hey, I got some this or that. And I'm no doubt that still can occur. It's a little, you have to be particularly sneaky. I think it's the combination of the alcohol on top of it. And then of course, that is also the group that is always outside smoking together. So it's a very interesting comment too, because that doesn't change as people get older, obviously.
This is an awesome, interesting conversation and topic though, because, and then you have cognitive decline and what caused the cognitive decline, combination of a million things. You have physical decline, and then you have physiology decline,
Yeah.
But the one thought I had when you're talking about, they don't do a lot of the trading of that, but if you have one person, I'm just going way on a limb here, who has financial or people on the outside that can bring stuff in. I mean, we also know that this is a high population for sexually transmitted infections. Like, are they trading other things?
Could be. And if you get one person in the group that has a car,
wow,
you're golden, because they go out. I know. I just watched the parking lot. I know who's going out and buying, because they come back with their multiple paper bags, and this is for so and so, this, and then they, run off to their. It's like you just went to the liquor store and bought for, your friends.
Like high school again or something.
High school, maybe in your high school.
And it's a huge need, I think, in this population as we start to see the age shift of folks that are living in our long-term care, assisted living communities toward, younger people. And often what it is that leads to them living there is they can't live on their own, sometimes because of, multiple chronic medical conditions, mobility, but oftentimes it's complicated by substance use and mental health.
Well, and if this is already is kind of a funny word here, but this is an issue right now already, like that right now in time, how, and we don't really necessarily have the right answers, or even like, we're just throwing out all these thoughts. Like, imagine what it's going to be like in 10 years, in 20 years, when we have this even larger population with more substances on board and or traumas and or living throughout in those settings. I hope you're not retiring for another half a century.
And there's very few of us coming up through the ranks. Yeah, I mean, I started to think, I was like, boy, I have cases that I could overwhelm this group with. I have another resident who, when you talk about the question of, potential for sexual abuse, she's in her late 50s, maybe early 60s, longtime alcoholic, liver failure, has a boyfriend outside in the community, goes out, comes back from the bar. She's very vulnerable. Doesn't have funds necessarily to purchase for herself.
It's like a dorm room with an RA, but with way more complicated everything.
Yeah.
Yes.
Like, you're adults, kind of like when you're in college, but so you don't really have a ton of control yet. That's fascinating. And
then intermixed with your kind of standard, kind of what we all picture as, the folks that are living in the assisted living, the 85-year-old, person who moved in from the farm because they were tired of cooking for themselves. And yeah.
Well, yeah, we could talk about this all the time. And we will, because we're going to do a geriatric talk that I'm pretty sure.
Yeah. Well, feel free to throw that case together too. We'd love to talk about
it. I will do my best. I started to look at it and I was like, oh my, it was overwhelming. And people are going to say, what? You're giving this?
I mean, you can just bullet point. You don't have to do any kind of fancy form. Just like a bullet point.
Her med list will take up 2 slides. I'm just saying.
That's fine.
All right. Well, it's 1:15, so we're going to sign off. Again, remember tomorrow.
Your poppy seed
talk. That should be a blast.
I just made almond poppy seed muffins on Sunday.
Kay Stengel at Stratus Health can get you hooked up with that. And again, remember Dr. Osterholm, that's through the MAFP. So you can go to their website and register. So,
yes.
All right.
Otherwise, 2 weeks, chronic pain and use disorder right here.
Super fun.
Thank you, everybody.